Dr. Disanayake, and we will have Dr. Deepanee to speak. There's a little change in the order. After Dr. Deepanee, we'll have Dr. Amit Porwal speaking to us.
Thank you. I hope you can see my slides.
Yes, Deepanee. Yeah.
Yes.
I'm seeing them single now, so it's good.
Okay. Right. Good evening to all of you, and thank you very much for giving us this opportunity. So my topic is about slightly difficult diplopia cases, because many patients come to our clinics with diplopia in a particular direction of gaze and a corresponding oculomotor defect, and we are happy to deal with them. But sometimes we need some knowledge in more difficult cases. Starting with the sixth nerve, whenever you think of you see an isolated sixth nerve palsy, you need to remember that the sixth nerve is vulnerable at several anatomical locations. Sometimes there will be many other symptoms and signs, but sometimes there could be just one. For example, corneal hyperesthesia may be the only other clinical feature which can happen in all these anatomical lesions, and hearing loss at petrous apex, pulsatile tinnitus in cases of posterior draining keratoconus fistula. Ipsilateral Horners could occur with brainstem and cavernous sinus lesions, and you need to differentiate them by looking at the area of anhydrosis. When it comes to the third nerve, whether pupil is involved or not is the biggest question. To say pupil is spared, it has to be a brisk pupillary reaction, and only if so with complete ptosis. Because if the ptosis is partial, it may just be an evolving third. It's also important to remember that if the ipsilateral pupil is smaller, then again that is significant, because cavernous sinus lesions can affect both sympathetics and parasympathetics, and so you can have a variable pupillary reaction. When you think the pupil is involved, you need to exclude the local pupillary defects. There are so many causes, and also this 35-year-old lady presented with pupil sparing third nerve palsy with complete ptosis of 6 days duration. She came 4 days after her third section. Both pregnancy and the surgery was uncomplicated. So since this was a medical third nerve, it was important to look at the possible causes, no features of myasthenia or exacerbated connective tissue disorders. So then I was a bit reluctant to ask her to go for neuroimaging, because this also happened during the peak of COVID Delta wave. But then asking more questions, I realized that she has had some issue with focusing and probably a smaller left eye 1 week before the complete ptosis happened. So there probably was some evolution. So it's important not to miss a surgical third, although the pupil was brisk. The pituitary apoplexy is a possibility, but she did not have any headache, or she was very, very stable. Pregnancy-related rapid growth of tumors has to be thought of. Both pituitary adenomas and meningiomas can enlarge during pregnancy due to the effect of progesterone. Finally, she agreed to go for neuroimaging, and she had this cavernous sinus meningioma. Since it's a cavernous sinus defect, that is why the pupil was brisk. You can see this was 2 weeks after. Most of her signs were going, and 1 month later she told me that she was nearly back to normal, although the tumor has to be monitored throughout her life. Sometimes diplopia presents with normal extraocular movements. Mind you, when you say normal, both Pursui and Sackerts have to be normal. One thing for sure is that usually there will be a very clinically obvious defect. The history helps. The type of diplopia, which activity is most affected, whether it is intermittent, whether there was a trivial head trauma, whether they are on CNS drugs, because CNS drugs can cause fusional defects without motility defects. Certain observations and examinations also help. You need to observe the head posture, the extraocular muscle velocity. You could do the occlusion test. And you could look for subtle signs like the lid position, the globe position and globe displacement, and whether there is nystagmus present. All these will help, and you can do other certain maneuvers. But sometimes the only other clinical feature is the torsion you see when you see the fundi. This sometimes appear before obvious clinical torsion occurs. Here's another case. Now, this 58-year-old lady presented difficulty in climbing down stairs for 3 days. She was very distressed by this symptom. The family members have also noted convergence twins a few days before the onset of diplopia. But she did not have diplopia for distance because they were homebound those days. Again, this happened during the pandemic. And there was an obvious right lateral rectus palsy. To explain her down gaze diplopia, there was no cyclovertical palsy. So I was thinking she had eyes also. So whether they are that, the duction is definitely better than version. So it has to be a neurogenic file, but it was only a non-arthritic AIUA with an inferior attitudinal field defect, which affected the diplopia checking on the left down gaze. She definitely could be a fourth nerve palsy. Although she had two ischemic palsies close together, a third ischemic palsy possible, but we were not sure whether it's quite likely. She also had contracted COVID 3 months before and diagnosed to have diabetes. Her blood sugar was fluctuating at that time. So even the time she presented, so 3 ischemic episodes is also possible. But then I kept on asking whether she has had any trivial trauma to the head, because that can happen without an obvious movement defect. We also thought of patchy lesions, but the MRI was normal. But the day she came with, I explained to her the various types of trivial trauma, but her answer was negative. But on the day she came with the report, she remembered a knock on the head by the dog's muscle. By this time, she was already getting better. This elderly gentleman presented with diplopia in primary gaze and bilateral adduction defect. Now see the eye movements. You can see the abduction nystagmus in the left eye and also in the right eye there, and also up gaze. You can see the up gaze nystagmus and down gaze nystagmus as well. So this was wall eye bilateral INO associated with the vertical nystagmus is usually due to concomedullary ischemia involving bilateral medial marginal fasciculi. Intermittent diplopia is also a common condition that sometimes put us off the mark. So myasthenia is the one that we need to. The orthoptic assessment helps especially if you ask for the correct things. It checks for committance, and the HES chart helps to identify milder defects, and it differentiates restrictive from neurogenic defects. Optokinetic drum helps the earliest sign in intermediate ophthalmoplegia. Double Maddox rod helps to quantify the torsion, and vertical fusional amplitude helps to differentiate between decompensating versus acute fourth nerve palsy. An upright supine test can be done to differentiate between fourth nerve and skew deviation. Because in the latter, the vertical deviation is reduced in the supine position. Worth 4 dots and prism interposition tests help to exclude malingering. Finally, I would like to draw your attention to some pitfalls. When you're checking for myasthenia, fatigability in myasthenic patients, if you keep the target for a prolonged period of time, you may get post-tetanic facilitation of the levator palpebral, and you may end up getting a higher lid level and missing the fatigability sign. Whenever you see an elderly or diabetic immunocompromised person, always remember chronic fungal sinusitis can mimic any single nerve palsies. When you come to secondaries coming from squamous carcinoma of breast can produce enophthalmos, and this may be difficult to detect in ladies with sunken eyes. Thank you, and thank you for tolerating my mistake with the.
No, no, Dr. Deepanee, it was very fascinating, and it's a subject which is not usually touched upon, so it broadens the perspective of all the viewers. Thank you so much for taking so much pains in spite of your